Hi everybody, and welcome back to This Month in Telemedicine. It's February 2017. We have a new president, Donald Trump. We have a new Congress that's back in. So there's going to be a lot of changes this year, a whole lot. And some of it will actually affect telemedicine. You're going to hear about that in a few minutes from Gary Capistrant. But first, there's a few other things I'd like to talk about just to get you up to speed on some things that are going on. First of all, new telemedicine practice guidelines. We set out a whole lot of practice guidelines over the years, and there are 3 new ones that we have out for public comment. That'll be due, comments are due February 17th. You'll find them on the web, and we've also sent those out to the membership. The 3 that we have are telestroke, and the 2 chairs of that work group that have put out the telestroke guidelines, Jill Berg and Bart Demarchek. And then we have child and adolescent mental health. Kathleen Myers and Evelyn Nelson were the ones who chaired that work group. And finally, pediatrics, which was chaired by David McSwain. Those are the chairs, but we have a lot of people who are involved in all of those and some research help. And I think you're going to find those on the web to comment on, and we would look forward to having that. They'll be approved when the board gets together next month. So it's a really important part of where ATA is. So we'd like to hear some comments from you, and I'm sure we'll have a lot from involvement with the various specialty societies as well. We also have a conference coming up, ATA 2017, the Transformation Advantage, Telemedicine 2.0, as we call it. There's a lot going on in that conference that you're going to see more about in the weeks to come. The education sessions are really important for this. It's following a little different path for us. It's what we call pathways for transformation. There's information in there about the research that's going on, some of the outcomes for each of the service areas in telemedicine. There are demonstrations on the floor of the equipment. There's presentations of case studies. There are guidelines. So if you're involved in tele-ICU, telenursing, if you're involved in emergency care, if you're involved in direct-to-consumer care, some of the other areas with chronic health, and on, there's a whole range of programs and sessions. We have our new program planner that is online now that is going to give a lot of information in the app that you can download. All the speakers, there's about 300 presentations, as well as courses and all the information on that. With the exhibits, we are almost sold out. We're about 30% ahead of last year on exhibits. It's a phenomenal year for that. So there's a lot of things to see on the floor. We've got 12 weeks to go before the conference, and registration is open. We're running way ahead of last year on registration. I'm very glad to say about that. We also have a lot of plenary sessions that are lined up and a lot of very, very impressive and important speakers that'll come to you. Pamela Peel from the University of Pittsburgh Medical Center is going to talk about the economics of telehealth. It's really important, people talking about, does this make sense in terms of the ROI? She has the data from a lot of studies, a lot of interesting stuff that's going to come out there. On Monday morning, we're going to have 2 speakers on meeting the challenges ahead. Patrick Kennedy, former member of Congress, one of the Kennedy family, is going to talk about delivering care to those in need. And also Thomas Friedman, who was the New York Times journalist. He's written a number of books, The World is Flat, a number of other ones. He's going to talk a little bit about some of the big trends that are facing us. Also on Tuesday, we're going to have a panel of 4 of the leading investors in the country on healthcare. They represent their companies, which are huge multi-billion-dollar investors. They're going to talk a little bit about the huge advance in money, the flood of money that's flowing into telemedicine and what that means and their own perceptions of where the industry is going. Of course, our president, ATA president, James Peake, former Secretary of Veterans Affairs, former Surgeon General of the Army, will be making a presentation as well as being available throughout the meeting. We have 3 spotlight sessions this year, one on women executives in telehealth, another one on scaling up from vision to reality, which is a demonstration, or rather a presentation from a number of healthcare institutions that are transforming themselves using information technology and telecommunications. And finally, a session on online consultations and where we're headed on that. And we have several of the CEOs of the leading companies in that space to talk as well. So there's a whole lot going on. I know in terms of registration, we've had a lot of members call in, and some of them have asking for their member IDs. This year with our software change and all of that, you can now get your member ID, just to let you know, if you go to our online consultation or online information place called The Source. you can get your member ID right out of that on the web. So there's a lot going on with that. One of the things we're going to be presenting on that, by the way, during the conference is our annual awards. The nomination forms are out to the members. If you need one, please let us know here in the office. The President's Award, dealing with individuals, for institutions, innovations, and a number of areas like that. And also the Industry Leader Awards nominations are out for that. And so we're waiting to hear from you. We have a nominating committee for all of that who will look at the awards and make some selections, and you will have a lot more for that going on as well. So that's just the tip of the iceberg of what's going on. Now we're going to hear a lot about the real big stuff, the policy changes that are underway as we speak. Hey, and we're back with Gary Capistrant, the policy guru, leader extraordinaire, man about town, at least in Washington town. Gary, I hear there's a few things going on with the new administration. What's his name again? Donald?
The Trump.
The Trump.
Yes.
He is in town. There's a few changes going on. Want to hear a little bit about him and what does this mean for the big world of telemedicine?
Absolutely. Well, we may soon have a new Secretary of HHS. The appointment of Congressman Dr. Tom Price should be any day. Maybe by the time you listen to this, that will happen. Then they've already nominated Seema Verma who was involved with Indiana Medicaid to head the Center for Medicare and Medicaid Services. So first of all, on the personnel level, those are the big issues. Other appointments are outstanding, such as head of the Food and Drug Administration and other important details. I thought for today that it would be good to focus on Medicaid, federal action on Medicaid, and then talk about what some of the states are doing on Medicaid and other issues. I select Medicaid because, first of all, there's a lot of confusion that people have between Medicare and Medicaid and why the states are able to do things with Medicaid that the federal government can't do with Medicare. And also, most timely is that Medicaid may be the first program affected by the new administration and Congress, even before dealing with repealing or replacing Obamacare.
Why? I'm sorry, why is that? Why would they work with Medicaid first before they do the big repeal of the ACA?
Because it's relatively simple to do, and they can get big savings out of doing that. So, first of all, it's important to understand what the differences are between the two programs, and the slide that you can see indicates that. Medicare is an insurance program, Medicaid is a welfare program. Medicare is for entitled individuals, whereas Medicaid is to the states that then pass that on to the individuals. So there's a number of important details that are useful for understanding why the federal level, it's so hard to get the changes, and at the states, that because the states have a substantial role, that you can get much more customization and innovation involved. Because of the nature of the Medicaid program, it's very easy for Congress to take a couple of actions to limit it. One of the concerns or interests is in capping the entitlement programs, and Medicaid is considered an entitlement to states, not to individuals, but to states. So there are a couple of relatively easy things that Congress can do. One is to turn the program into a block grant, that essentially you could tell each state that, well, you get for 2017 what you got in 2016, and add 5%. You can put a limit on the per capita expenditure. Another easy thing to do is to fiddle with the federal matching rate. The federal government in many states pays 50%. In some states, I think it's still Mississippi that goes as high as about 77%. So it's easy for Congress to play around with those rates. And it's easy to do because it just affects the state in the aggregate. It doesn't affect individual beneficiaries like dealing with the Medicare program. It may be the first out of the block. There are some indications from the White House that Medicaid is high on their agenda. Dr. Congressman Tom Price has talked about Medicaid reform and been supportive of it. It's something that the Republicans in Congress are very interested in pursuing. And one of the things is that what would be attractive to the states is to get more authority over how they spend they operate the program, what the spending is, and what procedures they have to go through. So the notion would be to make it simpler, to a simpler financial transaction with the states, and one in which would result in federal savings over time, but also then to give the states more authority to operate the program, just as the states may have more authority to deal with the replacement of Obamacare.
So I would assume that means also some significant cost savings over at CMS, because they're the ones who administer the Medicaid on the federal level now, and a lot of them are very involved in rulemaking and very specific program requirements, and if that all goes away, that could be a huge change in that.
In terms of staffing, yes,
Yeah, I would
you
think
could.
so, in rulemaking.
Right, yes, you could substantially reduce the Medicaid part of CMS.
So, of course, I got to ask the question, which I assume you're going to talk about next anyway, is what's the impact on telemedicine for this?
So, the impact for telemedicine is that this will generally be good in that it gives states more authority to operate, and also to the extent that cost becomes a much more important element, that then that's going to force the states and providers to do things differently and more efficiently than they have before.
And the states will have the authority then to open it up to use telemedicine however they think they can do it.
Yes. And it may be that one of the things that one of the ways that states handle it is to go to managed care, both more managed care, to have more of it at risk, and then even within and at risk to go to things like competitive bid, so that there is more emphasis on efficiency and effectiveness than exists now. One of the important things is that Medicaid, it's to understand the program, the 80-20 rule is pretty important. The 80% of the recipients are mothers and kids, but they're 20% of the cost. The 80% cost issue, but 20% of the population are nursing home patients. And so the ability of a state to deal with that is kind of limited. But the important thing is you need to stay tuned to changes coming out of Congress, considerations being given to start to adjust now to work with managed care plans that exist in your state, to think in terms of what the state might do to deal with less money over time, and to create the kind of networks and structure to be able to deliver healthcare services much more efficiently.
So I would think with the added flexibility that could be given to the states and the added pressure they're going to be having on nursing home costs, that the concept of using telemedicine and advanced technology in nursing homes, which really has not followed as much as some of the other parts of the industry, there could be huge opportunities in that, huge pressures to do it too.
Yes.
So that's going to be an interesting area where we're looking out for that in terms of the senior population in general, but certainly in terms of institutionalized population. I think there's going to be some interesting changes in that area ahead of us.
Well, and one of the easy things for a state to do, relatively easy, is to go after physician reimbursement and hospital reimbursement, and to the extent that they both can use telehealth more productively and more effectively, that will be one of the ways that they deal with the added cost pressures. So in terms of state activity itself, we do have our monthly call on February 23rd. That's a Thursday at 2 o'clock Eastern Time to go over state action. The state legislatures are ramping up. There's already parity bills that are new in Kansas, Massachusetts, Nebraska, New Jersey, and North Dakota. A number of other issues. We recently sent a letter to the Arkansas legislature regarding some attempts to improve their parity law and to deal with school-based telemedicine. Some opportunities back to Medicaid in Maryland, that some legislation to improve Medicaid coverage for telehealth in Maryland. A number of states are moving forward on the licensure compacts, and there continues to be some activity about licensure and practice guidelines. Like Connecticut is looking at legislation that would require an in-person visit before a telemedicine encounter, a step backward if they in fact enacted that. So a lot of activity, real activity at the state level, the potential for activity at the federal level, but 2017 will be a very exciting year, and you need to stay tuned to the next This Month in Telemedicine.
Thanks, Gary. One of the final thing I wanted to mention that, of course, one of the appointees of the administration, David Shulkin, is the new Secretary of Veterans Affairs. Certainly our current president, James Peake, welcomes him. He spoke at our meeting last year, as you know, and has been a real advocate for telemedicine, so I think we're going to have a lot of changes there as well. So that's it for This Month in Telemedicine. As Gary said, we hope to see you next month in This Month in Telemedicine.